So here are our objectives and agenda. You have a new treatment in the Epitomee capsule, a new tool in your toolbox. And we're going to give you an in-depth session on what that is and how it works. You will gain insights into the latest clinical results and obesity experts' perspectives, and you'll learn how to identify special patient subgroups who might be particularly appropriate for using this device. Here it is. It's a small capsule. It is not a drug. It is a device. It has been cleared by the FDA and the European CE. It's drug-free, it's hormone-free, it's stimulant-free. It's not a drug. It's a device. Therefore, it has an incredible safety and tolerability profile, which you're going to see. Here we go. Here's how the Epitomee capsule is dosed and used. You want to take it before your 2 main meals of the day. In my book, that would be lunch and dinner. It's a novel technology. It's science-based. It mimics food, but with no absorption, no stimulants, no strict diets. It only promotes appetite control, and we're going to show you how that works. It's a non-drug alternative. It's clinically proven, safe, non-pharmacologic approach to portion control and appetite regulation. It fills a treatment gap. We need approaches for patients who do not qualify for medications with a BMI of 27 or above, because this capsule and device can be used down to a BMI of 25. And it's also good for patients who do not need to experience any drug interactions, because it's not a drug, it's not absorbed, it's not systemic. It's simple to use and it's easy to adhere to. It could be used in patients who have GLP-1 intolerance. It could be used after completing a medication-based interventions. And anybody who is struggling with a non-drug and wants a non-drug, non-surgical approach to help them with weight loss. So I also think it could have a special place in individuals who are higher risk, because it's not absorbed, it's not systemic, it's not going to interfere with any of the medications that patients are taking. So it's a safe alternative for patients who have higher risk also.
So it's my job to talk through the clinical results of 2 of the clinical trials for the Epitomee program. I'm going to start off talking about the RESET trial. Here are my disclosures. And then finish up with the ELECT trial. So let's talk about RESET. This is the primary efficacy study here in the U.S. It's a double-blind, placebo-controlled trial. You can see the study design here, where we had a brief run-in period to ensure that people would be able to swallow the capsule, tolerate the capsule, and then a little bit of a washout, and then people were randomly assigned to either Epitomee capsule twice a day or a matching placebo. This was in a group of adults with obesity and overweight, so 27 to BMI of 40, who were non-diabetic, did not have type 2 diabetes, could be normal glycemia or pre-diabetes, and we were also assessing quality of life. So that's the quick overview of the study design. We only had about 14% of individuals who terminated treatment early, and you can see that the cause of termination ranged, but the number of people who terminated simply because of adverse events was relatively low, 1.5 to 3.5, 3.6%. And the adherence was actually really quite high. So that's a question that a lot of people will have. This is a twice daily application, very specific instructions about how to take it. But through actually looking at capsules and returned capsules and packets, we know that adherence was actually really quite high. So here's the money slide. What do we see in terms of change in body weight? And what we saw is that we had a statistically significant difference at 24 weeks, comparing Epitomee in the purple line to placebo in the gray line. And you see about a 2% difference in terms of mean change in body weight at that time point. And when we look at the other part of the co-primary endpoint, the proportion of individuals here hitting that 5% threshold, and remember 5% is where we're looking for in terms of starting to think about clinically significant changes in body weight. And we're seeing a significant difference of 56% of individuals in the Epitomee group compared to the predefined 35% threshold that we had to cross. 44% of individuals in the placebo group were achieving that 5% threshold. So that lets you know we had a good lifestyle intervention if 44% of people are achieving that, but you get 12% additional individuals achieving that. And then we see significant reductions in or improvements in health parameters like blood pressure, both systolic and diastolic, and improvements in waist circumference. These are all within group changes that are significant, not significant necessarily across treatment arms. These differences are significant across treatment arms related to glycemia and glycemic control. So we have the HOMA-IR on the left-hand side, and then on the other panel we have insulin. And what we're seeing is that we're getting greater blood glucose control as a measure of HOMA-IR with a lower overall level of insulin or greater reduction in insulin levels with Epitomee treatment. So as I summarize the ELECT study, this is the extension from the primary reset study. Individuals who lost 5% and then were continued on in an open label fashion to use the Epitomee capsule device for another 24 weeks. What we saw is maintenance of weight loss, and we saw sustained improvement in cardiometabolic risk factors without any signal for increased risk of adverse events. So gives us some confidence that starting people on treatment or initiating treatment after initial weight reduction can be very beneficial, both clinically and very safe for our patients.
I'm pleased to be here today as we are at the epitome of a new era in obesity drug development pipeline, no pun intended here. Today, we are going to focus on a specific time point in a woman's life marked yet by more significant physiological changes when estrogen declines, menopause. So let's move on to the fun stuff, the results. This shows the mean percent weight loss in the placebo group, which is 4.4% versus minus 7.6% in the treatment arm. Now over here, we see that 69% of women versus 58% of women greater than 50 years were early responders. We defined early responders as greater than or equal to 2% of weight loss at week 8, and this is consistent with the range reported by Jashik at ETL that was previously published. Here we see the proportion of women, 63%, 29%, and 13% who were able to achieve greater than 5%, greater than 10%, greater than 15% weight loss respectively. The majority of the patients did lose weight. The weight differences, which is the total average of an early responders versus percent of patients achieving greater than 5% and greater than 10%, were significantly greater in the Epitomee group versus the placebo groups. Here we see the change in BMI category. We also noted an increase in reversion of BMI from class 1 to class 2 obesity to lower risk categories, with some patients converting to normal weight as designated by the changes in red and yellow to green shown here. Now, changes in waist circumference were more profound in the Epitomee group versus the placebo, and here you see minus 4.8 reduction in the placebo versus 6.2% in the Epitomee group. This is the system organ class adverse events. They were comparable between the treatment versus the placebo groups. Importantly, gastrointestinal related events were less frequent with Epitomee. And so this is particularly meaningful for women above the age of 50 who often have higher health risk profile and are more likely to be using multiple medications. So the safety profile overall is very favorable and is particularly important for women who are at risk and who are seeking non-pharmaceutical intervention and therapies. So let's summarize over here. Overall, Epitomee is an effective, safe, non-pharmaceutical option for weight loss and metabolic health in women above 50 years, with 7.6% weight reduction versus 4.4% in placebo. and this is having achieved all of our primary endpoints as summarized on the slide here. There were greater reductions in waist circumference, more frequent shifts towards normal glycemia, and greater percentage of participants who shifted from higher obesity classes toward overweight and normal weight.
First up, hand poll. Just raise your hand if you are a natural skeptic. That's all I want to see. Who are the natural skeptics in the room? Okay, great. Now, who are the people that after seeing the evidence today and hearing about this have some mild excitement? And who are the folks that are like really excited? Does anybody say, okay, this is excellent, okay. Because I'm kind of all of those people, right? I, as a pathophysiology professor, as a person living with obesity, and as a clinic director of an obesity clinic, I move from skepticism to endorsement pretty slowly because I have had all the side effects of orlistat, and most of them publicly. So, yeah, it's you don't want to be that guy. So today we're going to look at how do I move from skepticism really into how do we get this into the clinic, right? So yes, I have 2 endorsements. I try to shy away from these things, but this is my movement from skepticism to into endorsement. And today is really going to be what I do in the integration science side. How do we move this idea into clinical practice, especially when it meets a gap? So when we look at potential candidates, well, what I did was talk to patients in my clinic and my students because I like to vet these things with people that I know. And I do the what about something like this. Because as a person living with obesity, I traveled with a refrigerated bag of meds and they wanted to upgrade my room for $40 a night to get a refrigerator. So I don't think the Epitomee people are noticing this right now, right? Okay, just we'll disregard they didn't see this, right? But the idea here is that the convenience factor is what many of my patients said. They have to be over 18, and if you're normal glycemic or pre-diabetes, a good candidate. But the thing that I loved about the ethos of the company is that they really endorse lifestyle, and that's something big in my practice. My clinic looks like a little fitness center. I cook with my patients. I eat with my patients. I dance with them. We work out. I have a 90-year-old patient that can deadlift 90 pounds. Like, yeah, this is awesome. So the lifestyle part, the fact that they take it seriously meant a lot for me. The idea that you probably see patients every day who say, is there anything that's non-surgical that I could consider first? Anybody have those patients? I'm just curious. Well, that's most of the hands. All right. So when we look at this, especially with the consistency of results across ages and genders, I get excited. Let's look at what some of my patients are saying. 48-year-old Emily, she's a teacher. She comes to me because of a problem she perceives on the scale. And she talks about hormonal hunger because she is going nuts. As she said, this last year with hormonal changes and her PCP didn't address that. So guess what the obesity guy does? Talks about HRT, and we start treating her perimenopausal symptoms because that was driving her, as she said, nuts. She was on HCTZ reluctantly from her PCP, and she said, if there's any way I can get off this, I want to. Is there something I can do? So we talked about obesity and obesity-related conditions and how treating her obesity would be an excellent way to treat all of her concerns. And then when she asked about this, I said, well, let me ask you, if something like this was available, and she says, oh my goodness, yes. When do I get it? Where do I get it? How do I get it? So her enthusiasm kind of buoyed my interest. And why would she fit? Well, when we look at the efficacy profile that's we see in the reset data and the early response, plus her motivation, plus the hormonal hunger that she's experiencing, we can see some great benefit potential for her. And an expectation that given all of these things, she could have a 6.6 to 9.3% reduction in total body weight. And so guess what she is? Calling me once a week using the patient portal. Is it ready yet? Is it ready yet? Is it ready yet? So hopefully it will be ready soon. John's a 48-year-old male. He's a truck driver. He drives across the country. So for him to carry meds inside his truck's now a feasible thing. So he's a great subset, especially given that he has pre-diabetes and he has dyslipidemia. Looking at the data, especially when you look at those HOMA-IR scales and the insulin reductions, great candidate, especially with the efficacy across genders, right? So same thing, we're going to have some risk reversal potential for him, but we're also going to improve the quality of life because driving a truck across country and dragging all those other things, that's a challenge. I deal with a lot of people trying to get in the military. Do you know one of the #1 reasons people cannot get into the military right now is obesity? So I work with a cohort of patients who cannot be on medications and they have to achieve certain goals before they get in. Alex is one of them with a BMI of 28. Isn't it great that the indication for this is 25? Exciting. This fits his need because one, he's motivated to do the lifestyle side. Two, he doesn't want a medicine. In fact, he says, I cannot be on a medicine, but he also aligns with that normal glycemic group. And then there's Sarah, one of our students. She's a PhD student, and she said, you know, the freshman 15, well, I've got the PhD 15. And it's not from the best eating habits. She's getting ready to defend soon, so she is just nervous and eating all the time. And she has a history of type 2 diabetes. She said, my mom got diabetes about 10 years after she finished her PhD program. I don't want to be there. She wants to halt the weight gain, but she doesn't want to use medications. She wants to keep with her lifestyle. And I talked to her about Epitomee, and she said, wow, is it available yet? Question you probably are all asking yourselves. But she'd be a great fit because this addressed some of that stress hunger. This is going to improve that sense of satiety, and that would help her not be snacking between meals, which she said was one of the biggest things that she's facing. And she perceives the benefit of a non-pharmacologic agent because culturally, for her, that's very important. But the idea here is that based on the evidence supporting the use of these capsules, we have a broad category of patients. Do you guys have, based on what we've talked and what I've illustrated, how many of you right now have at least one patient in mind who this would be a fit? Just curious. So the idea here is when you have this think about the safety risk profile. Think about the mechanism. Think about the relative limited amount of contraindications and relevant precautions, and that we can use this with coexisting cardiometabolic conditions. These are all wins for the patients that I serve, and most likely the patients you serve. So that is my abbreviated version, so we can move into something probably more important for all of you, which is our Q&A session, which will be moderated by these heroes to my right. So thank you for your time.
I think one of the presenters mentioned about the stress eating, that the device can be helpful with that. So my question is, how long does the device stay in the stomach? And how kind of in between the appropriate time that it's taken, does it help with the stress eating pattern?
About 4 hours, up to 4 hours. That's pretty good. Thank you. I think we're all walking out of here with a better idea of who might be appropriate for this new tool in our toolbox. So thanks very much. Let's do some networking and have some dessert.